studies of ipilimumab in advanced prostate cancer, and that in a phase 1 study of nivolumab, there were 17 patients with CRPC, and none of them had an objective response. We also know, and this is from Pam Sharma at our recent ASCO meeting, showing that CTLA-4 and PD-1 and PD-L1 are just the tip of the iceberg, and that the T cell interacts with multiple cell types that either help it work better or turn it down. Oops, sorry. But even with those negative IPI studies, there were always these one-off cases. And this is one of Tom Baer's patients who had metastatic castration-resistant prostate cancer. This was in the early 2000s, but after docetaxel. And he didn't want to go on chemo, so we went on a phase 1/2 study of ipilimumab. At the time, his prostate was still present, and it was so large it was pushing on his rectum, and he was constipated, and he had bone mets, and he got one dose of ipilimumab, and his PSA went from 650 to 500, and then he got part of another dose when it was discovered his LFTs were abnormal. It was held, and after 1 1/3 doses approximately in 9 years, he's like cured. I mean, he has no evidence of disease. He's not even on Lupron anymore. Oops. We also know now that we can give pembrolizumab and other PD-1 inhibitors for any cancer type that has microsatellite instability, but in prostate cancer, that is about 3%. So either we need to, I think there's work underway at UW to try to better define MSI in prostate cancer, and there are clearly other factors at play. I'm not going to beat you over the head with my study, but just to remind you that I had a study of people progressing with MCRPC prior to chemo for MCRPC, progressing on enzalutamide, who went on to receive 4 cycles of pembrolizumab while continuing their enzalutamide. We saw some pretty spectacular responses. But I do have an update for you, and we have a manuscript that's about to get its first rejection, so hopefully it'll be published soon. I went high, and I'll go lower after. Patient number 1 here, he started the study pembro in April 2015. He had previously been on abiraterone. His cancer had responded to enzalutamide prior to the study. PSA went down from 70 to 0.08, and his PSA is now 4.31, but technically he hasn't had a PSA progression because his PSA bounces so much. We never have a confirmatory value that's shows PSA progression. Patient number 2 who responded, same story. PSA went from 46 to 0.02. Unfortunately, he died of pancreatic cancer, which is really devastating. His PSA was 0.04 when he died. Our most remarkable responder, January 2016, started pembro, had not been on Abi, had responded to Enza. His PSA went from 2,500 to undetectable, and last month, if you look at his chart, his PSA is 0.00. His liver mets are gone. I mean, it's really pretty incredible. And then the next 2, they both responded to Abi. This guy continues on enzalutamide monotherapy with a PSA of 0.34, and our only responder who relapsed is this 5th guy here, whose PSA initially nadiered at 0.18, but then it came back up at 10 months. He was retreated with pembro and did not have a PSA response, and he just now has radiographic progression and will go on to something else. So kind of a sad story, but he did make it out about 22 months without any other therapies. There's also data from Fatima Karzai looking at the combination of olaparib with a different PD-L1 inhibitor, this time durvalumab, and she too presented some pretty remarkable results. So you can see here that the PSA response went down pretty great in a lot of these patients. But we should look at the patient characteristics too. Remember, this is on a PARP inhibitor plus a PD-L1 inhibitor, and a lot of these patients did have BRCA2 mutations. The 2 patients who did not have DNA repair defects who did have a PSA response. It was relatively mild. I mean, one patient had a PSA reduction of 46%, one had one of 10%, and we on my study did see some decreases that were on that order, but we didn't call them a responder unless it got to over 50%. So it's really unclear what the driver is here. Is it the olaparib? Probably. But there's many other studies looking at that combination. So how do we improve responses in prostate cancer to PD-1 and PD-L1 inhibition? Well, clearly we need to better select our patients. And now that we know that MSI patients can go on to Pembro, we have a marker at least that some of these patients could benefit from PD-1 inhibition. And then we could combine agents. So there's a lot of discussion about, with the other negative studies of PD-1 inhibition in prostate cancer, what was the contribution of enzalutamide on my study? Is it doing something itself to decrease, inhibition factors in the tumor itself? What is it doing? And there's a lot of interest in combining it with other therapies, especially immunotherapies. Dr. Gao is here, presented a slide yesterday showing that this is a study out of MD Anderson looking at a dose of ipilimumab, and that it can turn a tumor from a cold tumor to a hot tumor, meaning it's more infiltrated by immune cells. And prostate cancer has the reputation of being a cold tumor with not very many mutations. So I went through clinicaltrials.gov to see what are people doing now, and our study was first registered on clinicaltrials.gov in 2014. At the time, there was no other studies of PD-1 in prostate cancer. And now in 2018, you can find tons of them. Interestingly, so it's been mentioned by Oliver that Radium might be a good partner for pembrolizumab. After all, the phase 3 study of IPI in the post-chemotherapy study used radiation, and it was almost positive with a p-value of 0.053. There are other studies combining it with chemotherapy, so we'll see how that works. Listeria vaccine. There's this one out of UCSF looking at a toll-like receptor 9 agonist that's being injected into one of the tumors with pembrolizumab being used in addition. And then they're looking at hypomethylating agent plus a PD-1 inhibitor. And then there's current studies of combinations with Nivo and IPI, which we found is successful in melanoma, not sure yet in prostate cancer. Prosvac, and I'll take the chance. I mean, it's not exactly like CYP-T, of course, but 5 of my patients in my study had received Provenge or Siplusil-T, and none of them were responders. So I'm not sure how much that helps. And then again, for Nivo, there's Rucaparib, Enza, and docetaxel. So, but what's even, I think, a little bit more interesting is how do we better select these patients? And I think we need to do this, and we all want to do this in all tumor types, so we're not giving people autoimmune disease without benefit. So there is a study of Pembro at the Institute for Cancer Research in the UK looking at mutational burden. So they have a specific panel, and patients who have 11 or more mutations can join the study. And then for Nivo, there's a study also in Great Britain looking at the immunogenic signature. So in this case, it's looking at the number of mutations or the inflammatory infiltrate. And then at Hopkins, they're looking at ARV7 positivity and seeing if those patients respond better to checkpoint inhibitors. Thank you.
So quick question, Julie, in your initial manuscript, you had some MSI high for
yes.
some, but others were not characterized. And so maybe I didn't quite see that in.
You're right.
Yeah, I couldn't see it.
Yeah, it's
maybe it wasn't there.
Do you want to read? Yeah. So
okay.
We didn't require biopsies because we just want to see if there's activity. But if they had a biopsy, or they could be biopsied, they were. So this patient was biopsied and was MSI high. Okay. This patient was biopsied and low, and this patient was biopsied and low. And by low, I mean this guy had 26 mutations, that guy had 6 mutations. So, I mean, they were really low. I called Colin Pritchard, and I was like, well, maybe we're not using the right markers of MSI. Right. And he said, with this number of mutations, there's no point. They're not MSI high. These two did not have, the other two did not have biopsies.
Yeah, so basically biomarker not particularly helpful.
Right.
Oh, a little bit. I mean, you had some of the MSI. highs that responded.
That's true.
But on your non-responders, did you have MSI highs, or did you?
No, we did not.
You did not. Okay.
Mm-mm.
So, two questions. Firstly, how do you reconcile the fact that in the ipilimumab trials, they made the contention that the bone-only disease responded, yet the liver metastases did not respond? In your study,
Yeah.
very nicely, you're showing that the liver metastases are responsive, and actually no comment on the bone. It'd be interesting to see what the bone actually does. So how do you reconcile that, firstly? Secondly, do you get the sense that these patients are living longer? Because in our study with tezolizumab, the survival seemed to be somewhat better. The patients may not have responded, but they weren't progressing at the rate they were previously. Now, whether it's selection bias or something else, but it's just my sense that these patients are behaving a little bit differently than the typical castrate prostate cancer patient.
By these patients, you're referring to the MSI highs treated with PD-1?
All comers.
The general group,
Oh.
the general group of everyone. I mean, we didn't select in the Tezo trial
Right.
for
So-
expression.
Yeah, actually, I debated whether or not to include liver metastases, patients with liver mets on the study, and I was told not to. But I said that would be a barrier to enrollment. We just want to enroll this. So I have 28 patients. We had 2 patients with liver mets, and they were both responders. So how can I reconcile that? I don't know. They're 2 different compounds, the CTLA-4 and the PD-1. Maybe there's a difference there. It's interesting because the liver has its own environment with the Kupffer cells, and could that be helping somehow in PD-1, in the PD-1 story? And do patients live longer after getting Pembro, even if they're not responders? I think that's hard to know, but we do have a spider plot of PSAs, and it looks like, if you look at the spider plot, that if the PSA was like this before the study, it was like this after the study. So I don't know if that's true or not.
Hey, Julie, in the liver metastases patients, was there any possibility of a small cell variant in any of those patients?
In both patients, that was a nice place to biopsy, so we did biopsy those lesions and did not see small cell.
And what was the PD-1 status? Or the PD-L1?
For every single patient, 0. So PD-L1 is not a good marker. MSI is a good marker, but not the only one.
Right. And that's a baseline. Did you rebiopsy?
We do have some paired biopsies, but I'm not prepared to talk about them.
A lot of the, when they initially did PD-1, but then, tumor burden and even MSI high, all those are indirect markers. I mean, they're really not they're actually probably increasing the probability that there's some kind of antigen,
right,
neoantigen that's recognized.
Mm-hmm.
So again, I know that I think it's Columbia has been trying to characterize in Memorial, they've been trying to characterize what are the neoantigens that the immune system is recognizing.
Mm-hmm.
Typically they come out as kind of from viral particles or things like that. Are you in prostate, are you going to look down that road at all? Because that to me makes the most sense in terms of, if you're going to find something, is can you find the types of neoantigens that, again, the T cells typically recognize?
Absolutely, yes. So in the publication that'll come out, we looked at mutation number and number of neoantigens, and we're trying to characterize those individual neoantigens. As you know, they're different from patient to patient. It's not usually the same mutation found between 2 responders. So yes, that is the future, and I think that's why some patients have response. Yes.
Right. Hey, Julie, the abiraterone patients, were they on prednisone as well?
Yes.
Have you also looked at CTCs or cell-free DNA in this study?
Do we
have you looked at CTCs as a part
We
of
have
it?
CTCs. We have not examined them yet.